Hello, everyone, and welcome to the Lytham Partners Fall 2022 Investor Conference. My name is Adam Lowensteiner, Vice President of Lytham Partners. Thank you for joining us here today for a panel discussion co-hosted by Aurora Spine, ticker symbol of ASG, that is Alpha Sierra Golf on the Toronto Venture Exchange, and ASAPF, that is Alpha Sierra Alpha Papa Foxtrot on the OTCQB in the United States. Today's discussion is titled Aurora Spine, Simplifying the Complex, a discussion with medical professionals using Aurora products. We will dive into the discussion in a moment, but one reminder is that Aurora Spine is available for one-on-one meetings. If you have not already signed up, please send me an email at lowensteiner@lythampartners.com or visit the portal at www.lythampartners.com/virtual and click the one-on-one meeting button. Joining us today are Trent Northcutt, CEO and co-founder of Aurora Spine, Chrissy Ramey, National Director of Clinical Education at Aurora Spine. She's with Dr. Louis Razzo, board certified in both pain management and anesthesiology, located in Juniper, Florida. There's Matt Paxton, Area VP in the West for Aurora Spine, and he's joined with Dr. Ali Narizi, board certified in both pain management and anesthesiology based in Reno, Nevada. Before we begin with the discussion, I would like to each have you introduce yourselves and provide a brief description on your background. Trent, we could start with you.
Thank you, Adam. It's a pleasure to be here, and thank you so much to Lytham Partners for having us on this event. I'd like to extend out Dr. Rasso and Dr. Narizi. Thank you so much for your time and your energy and your efforts on this. Super grateful to have you on this call today, so thank you. And Chrissy and Matt, thank you for pulling everything together on your side. I know this is not an easy task to do, but we're honored to be here. So my name is Trent. I'm Trent Northcutt. I'm a CEO of Aurora Spine, co-founder of the company. We're a publicly traded company on the Toronto Exchange, bringing new advanced technologies to a modern new day in the world of spine, orthopedic, and pain management. With Aurora Spine, we have been able to now initiate new training programs and new technologies that both Dr. Rasso and Dr. Narizi have been intricately involved with, training over 100 doctors this year alone on these new technologies. We couldn't be more thrilled. So I'm excited about today's topics and getting into it, and I'll take it back to you, Adam.
Thanks, Trent. Chrissy, how about you give a little brief description on your background, and then since you're with Dr. Razzo, you can take it from there as well, background on himself.
Hi, I'm Chrissy Ramey. I'm the National Director of Clinical Education at Aurora Spine and Pain. I have a nursing background, mostly surgical, cardiac cath lab, labor delivery, and a little bit of neurosurgery as well. I worked politics for about 12 years, and then I went to work as the Director of Operations for one of the largest interventional pain society educational outlets in the space, the American Society of Interventional Pain Physicians, also known as ASIP. I ran that organization with the co-founder and president of the organization, Dr. Manshikani. And then from there, I got directly involved with industry and worked for an SCS PNS company and then a spine company. And I've been lucky enough to be here with Aurora since December of last year. I currently help the team run all of our regional and national education events. I also help plan and coordinate all the society events, labs, interactions. I also work closely with physicians and consultants to manage our REFINE study, collecting ZIP data, and our SILO registry system as well, collecting patient data. I manage a lot of our KOLs as well, and that's probably the most favorite part of this position of mine with Aurora Spine and Pain, is getting to be able to work with the phenomenal physicians and surgeons that are involved with this company.
My name is Dr. Louis Razzo, and I've been practicing in Jupiter, Florida for over 28 years. So throughout my practice, obviously, I've seen interventional pain change dramatically, and this is the next step with that. We're chasing technology. We're taking interventional pain management to the point that we're able to do procedures like the Aurora Zip, the Aurora Silo, and it's made a huge difference to our patients. And, it's been, wonderful teaching. I've been teaching for a number of years, and having the ability to teach this device has been great. We have physicians that really, by the time they leave the weekend, they're ready to go and do their procedures. We have a great discussion both, in the lecture hall and in the laboratory. We make sure that they're well trained, that they do a couple implants of each prior to leaving. And when they leave, they're ready to go out in the world and do these implants. This is making a huge difference to our practice. So thank you very much.
Matt and Dr. Narizi, why don't you each introduce yourself and provide a brief description on your background.
Hi, my name is Matt Paxton. I'm the Area Vice President in the West for Aurora Spine. I have been with the company since June of 2021 and started my medical background almost 20 years ago and getting into the medical device specifically 16 years ago with the neuromodulation company, and overall spent over 10 years with 2 different neuromodulation companies, really getting to understand the scope of the interventional pain physician and what they're able to do with their specialty, and have been able to see it develop and grow, and found out about Aurora through a physician friend of mine who let me know some of the exciting things that Aurora was doing, and had the pleasure of meeting Trent Northcutt, our CEO, and developing a relationship with him. And very quickly became evident to me that Aurora was partnering with the right physicians and offering the right therapies to this emerging and continually developing field of these interventional pain management physicians. So my job as an area VP in the West is to identify and support the appropriate physicians that are being trained on these procedures, to provide case and technical support in the operating room, as well as educate the advanced practitioners in these practices on the correct patient selection, and to support physicians like Dr. Narizi in the efforts that he's doing up in Reno, Nevada, to bring these therapies to his patients.
Hi, and hello everyone. I'm Dr. Ali Narizi. I'm a board-certified pain specialist, interventional pain specialist, and anesthesiologist. I've been practicing in the pain field for over 80 years in the state of Nevada. And my practice is called Reno Pain Associates, and I founded the last 2 years, almost a year and a half ago, the first pain urgent care in the United States called United Pain Urgent Care. So what we have seen in our practice, typically from patients at the time of the injury, by the time to get to us, they may just get so many other treatments that may not be helpful. So by introducing the idea of acute pain injury, so we're trying to identify and intervene these patients in early stages to help them find them through. So what we have seen before in the field of pain management, initial with conservative treatments, then some of the minimal invasive treatments. Now we got to the point that we're able to basically provide A to Z treatments, sometimes when it comes to spine treatments, such as the Aurora Spine product. So it's been a tremendous help to us. And the beauty of it is we also generated evidence. That's something that my side, and I was involved in different clinical trials for a medical device company. And this beauty is we see that we're providing that evidence to see not what we have seen with our patient results, but we're confident that you can produce this evidence everywhere and with any physicians. The treatment is safe, and that's what we want to see. Our field, it's very similar to cardiology, that if you and we were talking 30 years ago, no one would believe in stents just to do the same thing for chest pain, angina. But now it's a routine treatment instead of doing cardiac bypass surgeries. So we're moving towards that idea. People, they do understand that you don't need just to do extensive surgeries for a situation which is not extreme. So that's what we believe, that they're most 2/3 of the cases, they don't need that extreme work. And Aurora Spine can be perfect fit with a great outcome, like it's standing in our cardiology field. So I think the future is bright, and that's why we're excited just to be part of this, because all of us can go back in a few years from now and see what we have left for our patients and for our communities. Thanks.
Great. Thank you, everybody, for that. Now let's dive into some topics of interest. Trent, let's introduce the conversation with a little background on the trainings Chrissy has spearheaded, and bringing in Drs. Raso and Narizi to discuss maybe a little bit of Aurora products that they use and their experiences with those products.
Yeah, I'll start with how the training kind of first developed. We first got together in Las Vegas, Nevada. We had a 14 personnel ground table discussing the idea of moving the ZIP MIS product into the hands of interventionalists. Many of these people who have participated at this event all were from a competitive company called Vertiflex, a very good company that was acquired by Boston Scientific. And we were really intrigued by the training that these doctors were provided, and also how they were now teaching other doctors on how this procedure is working for them. So the roundtable went really well, and we decided that this was a go for us. We did a cadaver lab later the very next day, and the turnout was terrific. And we knew right then and there we needed to add more people to our team, and this is where Matt Paxton got involved and Chrissy Ramey got involved. And of course, I was honored to meet with Dr. Rasso and Dr. Narizi. And these gentlemen have really, really embraced our training program. They've not only have they trained, hundreds of doctors outside of Aurora, but truly they've trained hundreds with us, and we've really taken it to the next level. And Chrissy's done a really great job with the idea of a hands-on approach with a blend of ortho, neuro, pain interventional doctors where they're collaborating. We're bringing this bridge together with these doctors to teach across the board on the minimization of what they're going to need in this procedure, the recovery time, the coding, the reimbursements, and then what are the pitfalls? What are the upsides? What are the downsides? Everything about it. And the collaboration has been tremendous. I got several videos of Dr. Rasso teaching one-on-one with the doctors that have been at his stations. Same with Dr. Reezy, where he just pulled somebody aside and chat with them and give them that one-on-one talk. These are the kind of things that Aurora is looking to do and continue to advance on. And I'm really pleased with the way that the team has pulled together in these training programs. Chrissy, what else do you have for us?
I think the biggest part is, the point that you touched on of how we really bring surgeons and interventional pain physicians together and provide a collaborative teaching atmosphere for interventional pain physicians. Having that surgical relationship and partnership is very important to interventional pain physicians as well as it is surgeons. They support each other's patients. They refer each other's, patients within their local practice areas. And so really having that collaboration is very important. Another thing that I really look at and love and honor about our physicians as they come to the trainings and provide the educational opportunities for others is that they're reachable. They all provide cell phone numbers and email addresses and offer case support whenever the attendees go back and they're ready to start implanting patients. Every single one of them are quick to answer their phone calls and their text messages with questions, whether it's from me, another member of our team, or their fellow physicians. And our surgeons interact with our interventional pain physicians in the exact same manner. And that is probably the one thing that I am most proud of with this training and education program is the collaborative effort that we're able to bring the space between surgeons and interventional pain physicians.
Excellent. Dr. Narizi, tell me a little bit about your experiences that you've seen in the training programs and some of the doctors that have asked you questions about the procedures. Start with Zip.
First, start with why I got involved in Zip. Sometimes, it's just the treatments that come to you, and we've done teaching before in the past for physicians, but also first thing comes to my mind is not I'm able to do. Is it going to be a safe procedure that majority of our physicians who are trained in the field of space of interventional pain are they able to do? Because if I'm coming out as ambassador for my field, I want to make sure that first we do not harm. The treatment is safe to perform, and that's what I have seen first that I tried to implant it, and that was the confidence I got enough that this is a very safe treatment to do, and in hands of all interventional pain specialists that have had good training, they should be able to perform this procedure safely. So that was the first check mark. That's a big part because we don't want a treatment only for few patients. That's not the point of what I'm doing. I'm doing something that I can leave a good work for many physicians years to come to do. And that was the first thing with Zip. So then the outcome itself in different training programs, we've seen that people we've trained, they go back and implant, and we've had friends which mostly our colleagues, people trained are also friends of ours as well, because this small space in field of pain management we have. They call me and they ask me to come down. I have another physicians who had the training, and I said, Narizi, can I come? I said, okay, just I'll put 2, 3, 4 cases for you. Just come down Friday and see what I do, because you have had some questions in terms of like dissection, for example. So that's the availability that most of my colleagues, they do have when they train the physicians. We're always there for them because we know the evidence, the results right there, the treatment is safe, and also the help that they need from us is there for them just to be able to continue the right treatment for the right patient.
Excellent, excellent. Well, you guys have been nothing more than just absolute excellent in the room with the trainees. You participated at multiple events. It's been a pleasure to have you on board with this. Why don't you talk to me a little bit about zip versus silo in your perspective? They're two different procedures treating two different things. Obviously, your practices see a lot of back pain, and they also see a lot of SI joint pain. Dr. Rasso, can you tell me a little bit about the back pain versus the SI joint pain you see in your practice?
It's funny, there's been so much attention lately with SI joint pain, and I think we've overlooked it for a long period of time. Patients would present and you would ask them where the worst pain was, and they would point to the low back. But what we've learned over the past few years is that they may be pointing to the low back, but it's actually lower than what we thought. And if you look at it, it's right over the SI joint. And so these patients have, motion at that joint. And so with the zip, you're eliminating that motion. So these are patients that have had a lot of lumbar surgery in the past. And once you do that, you have adjacent level disease. And once you have adjacent level disease, the motion always goes to the adjacent level because those segments above have been fused. So the SI joint, even though it doesn't really change much on the imaging, it is a pain generator. And the number one job we do in our office, and Ollie would agree with me, is we have to identify the pain generator. Now with SI joint, there's a very specific way of doing that. Besides the history physical exam, we can do a diagnostic block and we can identify the pain generator within an hour of the block. And we have to document 2 of those blocks prior to getting insurance approval. As far as the zip, it's another great device. As far, because we have patients that we've been treating for years for lumbar spinal stenosis. And in the past, our aging, the population of our patients and the age of our patients have aged. And so these patients are not candidates for a huge open procedure with multiple levels of hardware. So we have to offer them an option. Once they've failed conservative therapy, whether it be epidural injections, physical therapy, even some medication therapy, we have to offer an option. This is an option, and it's an outpatient procedure, 30 to 40 minutes at the most. And you're relieving their symptoms of spinal stenosis, or what we call neurogenic claudication. These are patients that have pain that starts when they stand, worse when they walk, and is relieved when they're sitting down. So it's a great device for that. And actually, Aurora and the Zip device actually takes it to the next level. In the past, we were very hesitant to treat any patients with severe spinal stenosis. The Zip can be done in patients with severe spinal stenosis. Also, when they have any kind of slippage we call listhesis or responding, we could only treat a grade 1. With the Zip, we can actually go to a grade 2. So these are patients, we don't need a new referral pattern. These are patients that we see, if physicians come here for training this weekend, they can go to their office on a Monday morning, and their first patient that walks in may be a Zip candidate or a silo candidate. And so these patients are there. We don't need to go out and market to get a new referral pattern. These are patients that we can treat better in our office, even in existing patients. So thank you very much, Trent.
Thank you, Dr. Rasso. And the difference between Dr. Rasso's practice and Dr. Narizi's practice, you're in Florida, and Dr. Narizi, you're in northern Nevada, right on that border up there with Northern California, all the surrounding states up there, Oregon, Washington, Wyoming, and so forth, Idaho. Tell us about your practice in your area and how this has helped your practice out, Dr. Narizi.
And for us, one thing that is how we can make sure that that we are able to deliver the treatment in the right time for the patient. As Dr. Rasso said, a couple of things we always look for. The right treatment for the right patient at the right time. So every time you may have a great treatment, but if you pick up the wrong patient, so that's why, as Dr. Rasso said, if the generator of the pain is not your spine, is a side, if you do the Zip, you just have a great technology, great hands, you're not going to get the result. So that's what when the training comes is to not only how to implant, and the implant over time you can learn, but also how to teach to identify the right patient for the right treatment. And in our community is the same part, that when we identify these patients, now it's not something that they have to wait, go through different times from me to refer to someone else to do a different procedure, more extensive procedures. So imagine these patients, they have to suffer. Not only that, they may just lose the time to work, they may get dependent on the narcotics and opioids. So there are a lot of even just the problems that you do see cost-wise, economically, just how many times they may just go to ER because they're suffering, they're waiting to be seen. for that matter, or your referral is not going through so fast. So you've seen that. Now this is different. The patient comes to us, can get the physical therapy done, can get the conservative treatments done. So we can walk them through the algorithm easily. And again, from A to Z. Okay, this is a side joint. I've never had a problem. Let's just see if you do respond to physical therapy, and then respond to some of the like NSAIDs or anti-inflammatory medications, then injections or ablations we do, the diagnostic. We're able to kind of walk the patient through, make sure that they get the right treatment, and we perform the surgery which is right or needed for them. And that's the beauty of what we do. And I think it's just even not region dependent. All across from the West Coast to East Coast, the problems are the same. So what we see that I think people, they do suffer from same problems, but you have to offer them the right treatment. You don't have to sometimes offer very extensive procedure for something that you don't have to do. And I think that's where Aurora Spine comes to play, to not address only the spine, but also address the sacroiliac joints, so both of them.
Quick question for both of you. How many procedures have you guys performed Aurora products in a hospital versus a surgery center?
I've done 100% of all my procedures in a surgery center, and I think that's a huge advantage. These patients have a short procedure. They're in recovery room and probably an average of 45 minutes, and then they're discharged. You know, we make sure that we follow them with phone calls daily. A lot of times we'll have them even send screenshots to get wound checks. And then we see them back during their immediate postoperative period a couple of times within the first few weeks. And then we advance their activity level as time goes on.
Dr. Narizi, what about you?
Yes, for me, it was was the same as well. Majority of the cases are happening in ASCs. The only ones that typically go into hospitals with one of our the payers that we have, it's a local payer that only allows you just to perform the procedures in their own facility, like Kaiser, but ours is Hometown Health, which they don't have ASCs, they have hospitals. So and when they come with that kind of payers insurance, I have to take them to hospital for those procedures. Or if the patient has some we typically consider as ASA, so it's a clinical for how sick the patient can be. And this is another beauty of it, because these cases are not even the surgical cases with pedicle screws, because the amount of the time of bleeding, anesthesia, things are related, but we're not concerned because we know that there's not much of bleeding involved. It's going to be quick, but also the nature of the sickness, they have to be in hospital setting for anesthesia purposes post-op. And that's another reason that we do them in hospital, but majority of the cases are being performed in ASCs for us.
And both of you are participating in our ZIP multi-center study. How do you feel about the multi-center study as it relates to a fusion for a pain interventional doctor to be performed on with the patient, and a ZIP multi-center? What do you think the benefits of putting out a multi-center study would be to our listeners?
I think, no matter what you're doing in our field, we have to collect data. And I think it's data not only for us, but also for the insurance carriers to show that we have not only 6 months of data, 12 months of data, we have multiple years of data. And I think that's what's going to come down the road. That's going to make a huge difference. So if it's a multi-center, my experience may be different than Dr. Narizi. So it's important. Florida is not the same as Nevada, and just like other areas. And I've been happy to participate in that. And actually, we're working on our first publication to come out. And it's been great collecting the data. It's easy to collect the data. I have a research coordinator in my office that helps with the data collection, and I think that's going to be important. I think that's going to get a lot of people's attention when that paper is released.
Dr. Narizi?
Yes, the evidence is the key for us. It's called evidence-based medicine. So we perform everything based on evidence. It's not based on my experience to tell colleagues, okay, it's great, just let's go. No, everyone at this point want to have evidence. So as what you have seen that with type of Aurora Spine, we want to generate that evidence that besides first, it's a safe implant. Look at the complication rate and where we are with that and what is it. So the safety is the key for us to show it's completely safe. Then the efficacy of the treatment for long-term that we see in patients, how well they are doing over time. And that's what we're collecting. That's what we've seen. And when at the end of the time that and in the study, I think we're able to generate a good evidence for our colleagues that what we're doing and for the field, because then it can be done in different areas for different payers to look into the posterior approach or posterior fusion into laminar or anterior spinous procedure for us with a good outcome. And that's what we look for our patients, for our communities, to see that evidence soon.
Excellent.
And I think it's really important that we, if you look at even some of the evidence for spinal fusion, they had the sport data, and that really showed at 4 years there wasn't much of a difference. So I think if we collect, multiple years of data from a multi-center study, I think that's going to be important to show that long-term we're getting good success with this device.
Each of you play a different in improving your patient care. How have your patients done on your post-op care? Tell me a little bit about how the patients have done. I'll start with you, Dr. Rasso.
It's amazing, other than the surgical pain, they notice in recovery rooms, since now that you've created that space where the spinal stenosis was, that their leg symptoms have improved dramatically. So they walk out of the surgery center better than they walked in. They will have some surgical tenderness, and we educate them to expect that. But we want them to be functional from day one. We want them to go and, stand for longer periods of time, walk for greater distances. Obviously, we want them to do it in moderation in the first week or two, but we want them to actually prove to themselves that that device has helped them to be more functional, to not only participate in activities of daily living, but actually to work with their family also.
Dr. Narisi?
Yes, I agree. The strongest proof that we have is doing the cases in ASCs. How many fusions can do in ASCs and discharge the patient right away? And at this point, I've done a good number of these cases, had 0 patient needed to be admitted overnight from ASCs. So from ASC standpoint, and so that shows the recovery time is much faster, easiest for the patients to go through the cases. But also in a case that we have few of them, they needed, pain can be extreme because patients' tolerance are different. But these are not the majority. They're very minority of people, because there's this nature of what we do in medicine. Nothing is 100%. Nothing is perfect. So the pain in people for recovery, we look at always the majority of the patients, how well they do. And that's what we've seen with Aurora Spine, that after surgery, in an hour in the PACU, and they're set to go home, maybe with the 2-3, typically it's just like a 72 hours of pain for them, and then they start getting much better after. But the relief from their chronic pain sometimes is very immediate. It just, as Dr. Rasso said in the PACU, said, Dr. Neres, I don't feel that shooting pain down to the leg anymore. So that's what we've seen. That's amazing with that you can see the results right away, and the post-procedural pain is going to be way less, and hopefully we can even evidence comes on the study to show that as well.
And I actually try to make a point of going to recovery room and telling the recovery room nurses that I want to see the patients before they're discharged, and I want to actually take a little stroll with them in recovery room, just to let them know that there's already a dramatic difference, and just seeing the smile on their face is worth it.
So to be clear on that, you're actually getting the patient up off the bed and you're walking with them?
Yes.
See, that's amazing, right? If you got a patient who comes in that day, they've had pain, you've been treating them, you've been trying to get them, again, staying away from the opioids if you can, trying to reduce that in your practice, trying to make sure you give them a clinical outcome that's going to be positive for them, and you're actually getting them up and off the bed in the operating room.
Some of these patients couldn't even get to their mailbox to check their mail. I mean, just walking out to their mailbox was so painful for them. Some of them standing at the sink, they would have to put a chair or a bar stool near the sink while they're working at the sink in their house. So these are dramatic differences. And just by creating a few millimeters of difference in the spine with stenosis, takes them to that asymptomatic stage in their life.
We've been talking a lot about clinical. We've been talking about patients. We've been talking about the product a little bit. What would you say, both of you, if you were speaking to an investor about Aurora and investing into Aurora and buying stock in Aurora from a doctor's perspective? What would you tell a potential investor? I'll start with you, Dr. Narisi.
I said the future is bright. That's all I say. Like, and I believe we are just the beginning. I think what we need to do more is just the message now. People, they know, they may not know. I've come across many of them. They think that, oh, if the surgery is the pedicle screws, that's the way it is. But they don't know that there is a treatment that can be done in a safer fashion, outpatient, without intruding into the spine significantly. So that's why I think over time, people, they know, they see the outcome, they see the results. It's been our practice that we see that how much we've grown in terms of the number of the cases we started at the beginning and the people that come back because they've seen, they've heard about, for friends have done it. I have had golfers just doing the same treatments of the fusion. So that's what I'm saying. The future is bright because we are just the beginning and people will see. This is like an extent in cardiology field versus the open heart surgery.
I completely agree with you. Dr. Rasso?
The future of medicine, and have you seen over the past few years, is minimally invasive. And just like Dr. Rizzi said, there's open heart surgery is one thing, but going through and even peripheral vascular disease has changed as far as stenting. So this is just the next step. This is minimally invasive. We as interventional pain physicians, we know the spinal anatomy with a fluoroscopy better than anybody. And we're able to do these procedures quickly, efficiently, safely, with good outcomes. Like Dr. Narisi said, I haven't had any patient that's ever required any kind of hospitalization. And so we want to continue with this. And this is the way Aurora is moving. It's moving in that direction. I think this is just the beginning of the direction that Aurora will continue with. But to have these devices in our hands to treat patients that are sicker, they're on anticoagulants, they have cardiac issues, they have pacemakers. These are patients that aren't candidates for open procedures, or if they require an open procedure, it would be a 3 or 4 level with pedicle screws and rods. This is actually a reversible. The Aurora Zip is a reversible procedure. We're not really destroying the anatomy when we're doing that. So we're preserving, the sagittal alignment or the alignment of the spine. If patients should require anything down the road, we haven't stopped them or prevented them from having any further therapy. So patients are sicker. There are a lot of them on anticoagulants. The medical workup, the medical clearance is key, but these are patients that are ideal for this, a minimally invasive procedure to give them a better quality of life. And that's what it's all about.
Absolutely. Now, I've asked a lot of questions. I'd like to hear from Chrissy because she's been the one in charge of all these training programs. Chrissy, why don't you tell us a little bit about what you accomplished this year and where do you see our training education program next year?
So when I originally came into the company in December, it was like, well, what have you guys done before? And it was like, we've kind of done some things. And so I really had a good opportunity to take something that had been started and really see it to come over a, so-called finish line by the end of this year. We've moved some KOLs around. We brought a lot of really amazing people in that were not here originally. We've really helped our KOLs develop solid relationships and friendships with the people who have come in as attendees and learned. We have, used our KOLs and our educators to proctor cases on live patients and continue that education and teaching opportunity. We're actively developing a new hire training program as we increase our sales force. I'm also developing, with the help of the field team and some of our KOLs, an advanced practice practitioner education course. We've expanded our footprint with our society meetings, and really our labs themselves have expanded their footprint. We were doing 2 to 3 national labs a year when I came in. This year we've done 3. I believe we've done 11 regional labs as well. And we've gone to all the society meetings that, we were physically able to attend. The feedback that we've received from the changes to the education department and our marketing work that we've done, it's all been great. Like it's a company effort. I can't do what I do in education without our marketing department. Marketing can't do without our sales team. And it's just a cohesive company that allows things to move forward with beautiful progress and beautiful growth. And I'm incredibly honored and excited to be here and see what happens over the next year, considering what's happened over the last year.
And you mentioned feedback, Chrissy, and your feedback has always been tremendous. You've got a lot of feedback in from the doctors. Matt, you're out all across the West Coast, going up and down the coast, all throughout the Midwest there as well. What's the feedback been for you in the operating room with distributors and also with new doctors?
Yeah, it's a good question. So, to follow what Chrissy said, I mean, Chrissy really helped us bring our education and training to the next level where we wanted to be. One of the exciting things for me, having been in medical device specifically for over 16 years, was being able to just look at companies and seeing where companies have been and where companies are going and who's innovating. And as we go over the zip procedure and we show the silo procedure and we have taglines like simplifying the complex or simple, safe silo, and you show a new physician the brilliant yet simple ingenuity of the zip implant, and they're amazed by it. They're like, I don't need screws. No, it's a screwless fusion. I don't need this. I don't need that. No. And so the feedback's tremendous. They're asking for it. Insurances are asking for it. They want these patients to go home the same day. They don't want them in the hospitals. That's why these innovations are going from hospitals to surgery centers. And, for me, joining a company like Aurora is answering that call to continue to innovate and make things minimally invasive and physician-friendly in the interventional pain space. And so I think we're answering that cry, and we just need to do more trainings and more education because the patients are doing phenomenal, and that's the primary endpoint, to make sure that patient outcomes first, and then to put this in all the appropriate physicians' hands that are asking for these procedures. But the feedback's been overwhelming. I don't have a single physician that's been trained that says not for me, or I didn't like it, or I wasn't impressed by it. We just need a larger megaphone to continue to spread the word and to let people know about the amazing things that we're doing at Aurora.
Well, speaking of spreading the word, that's what we tend to do here. And this is why we wanted to have the two of you doctors join the Lytham Partners roundtable discussion point. Adam, are we missing anything? Is there anything else we should be touching on?
No, I think that was excellent discussion. I appreciate everyone's time. If that's okay, Trent, I think we could wrap up.
That's fantastic. Dr. Rasso, Dr. Narizi, we thank you so much. I really appreciate you. Look forward to seeing you very, very soon. Chrissy, thank you. Keep up the good work. Matt, keep up the good work. And Adam, again, thank you. Thank you, everyone.
Sure.
Thank you.
Thank you, everybody.
Thank you, everyone.
Appreciate it.